Presentation number 8 in Neurovascular Imaging Series, prepared by Prof. Sharaf and revised by Prof. Rami Edward. It will be dealing with vascular malformations. We have many types: parenchymal, or what's called Bayal malformations, dural AVM, mixed both. We have capillary telangiectasis, cavernous malformations, venous malformations, including venous anomaly, vein of Galen aneurysm, and venous varix. AVM is 98% of all AVMs are solitary, 80% parenchymal, 20% mixed, and in 25% shows calcifications. It replaces but not displaces. That's why it's not having much mass effect except with hemorrhage. Complications: hemorrhage with a parenchymal, subarachnoid or interventricular. Superficial venous drainage into cortical veins without an intervening capillary network is usual. Parenchymal 80%, dural mixed 20%, 25% are calcifications. It replaces but not displaces, except if there is complication as hemorrhage, whether parenchymal, subarachnoid, interventricular. It could produce a mass effect. The drainage is superficial venous drainage into cortical veins. Dural AVM, parenchymal AVM, usually associated with edema. Sometimes it can be mixed, dural and parenchymal. This is cerebral AVM with hemorrhage, not seen on angio if small and compressed by hemorrhage or thrombosed. It might show steel phenomena. That's why the pericallosal artery will be prominent from the MC, the anterior cerebral. That is the pericallosal, more prominent than the anterior cerebral or callosomarginal, and that's why this is called steel phenomena. AVM, parenchymal. AVM supply from the posterior cerebral artery and venous drainage into cortical vein. Large AVM involving the ventricle. Falcine AVM. Tortuous flavoid vessels from middle cerebral artery, and again here it is both parenchymal and dural, with drainage into superficial cortical big vein. Blood products of different age left at the left thalamus and with surrounding edema, and again there is a big draining vein seen. In the spinal cord there may be AVM, could be true, congenital or acquired secondary and inflammatory process that leads first to venous thrombosis and subsequently to a direct fistula. This is the appearance of spinal AVM, seen as tortuous vessels within the spinal canal, which could be capacious, and in contrast examination of the myelography, you'll find it as tortuous filling defects. Spinal, with large cortical draining vein. Now capillary telangiectasis, nest of dilated capillaries appear as foci of increased signal intensity on contrast enhanced MRI, commonly coexist with cavernous malformations, capillary telangiectasis. This does not present at birth, but almost always develop by 6 months. In contrast, vascular malformations such as lymphangioma and AVM are present at birth and show progressive growth into the adulthood. This is capillary telangiectasia on the surface. This is how capillary telangiectasia can appear, and of course we need to differentiate from other similar appearances. Cavernomas, amyloid angiopathy, metastatic hemorrhages. Now this is sinus pericardiae, dilated sinus pericardiae, seen as defect, traversing the calvarium into the intracranial dural sinus through dilated diploic vein. Dilated diploic vein. Here we have extra and intracranial veins connected together. The differential diagnosis is a subcutaneous cyst with pressure atrophy on the nearby bone or a lipoma. Differential diagnosis of a lytic lesion in a child mainly could be sinus pericardiae, could be eosinophilic granuloma, fibrous dysplasia, hemangioma, infection, or very rarely metastasis. Congenital as sinus pericardiae, eosinophilic granuloma, fibrous dysplasia, hemangioma, and infection. Cavernous malformations, dilated endothelial lined spaces without normal brain tissue. This is called the popcorn lesion. It contains blood degradation products of different stages. 80% supratentorial, 80% multiple. Black rim, popcorn-like core, and this is appearances of cavernomas. Multiple in 80%, multiple in 80%, and supratentorial in 80%, with different stages of blood. Multiple cavernomas here and there. Multiple cavernomas. You search for others because 80% it is multiple. Here it is. We have weak one, and it is bleeding as seen in T1 weighted images with contrast here. T1 weighted images showing bleeding. T1 weighted image with contrast showing the whole cavernoma. Endothelial lined spaces without brain tissue. 80% multiple, 80% supratentorial, but famous for the posterior fossa. Multiple cavernomas with calcifications. Cavernomas involving the posterior fossa. Differential diagnosis of such an appearance, as we said before, is the multiple cavernoma, amyloid angiopathy, hemorrhagic deposits, capillary telangiectasis, and of course hypertension. But in hypertension, the hemorrhages are usually at the basal ganglia. Then we have the developmental venous anomaly as venous angioma, multiple small veins converging into a large transcortical draining vein adjacent to the frontal horn, usually venous angioma. Developmental venous anomaly. Here again another developmental anomalous venous drainage, abnormal venous structure, developmental venous anomaly. Thank you.